webinar. Our topic for the day is vasopressors and inotropes, and I'm happy to introduce our speaker today. Our speaker today is Dr. Alisha Choudary, ma'am. She is a consultant in Department of Critical Care, Pulmonary and Sleep Medicine in some Ultimate Medicare Hospital, Bhubaneswar. She's on the editorial board of Critical Care Communication Newsletter 2025-2026, EC member of ICCM Bhubaneswar branch. She's also the EC member of Odisha Chess Society, winner of an ICS travel grant, winner of best paper awards in national and state conferences, and has multiple publications in national and international journals and chapters. And her key areas of interest are mechanical ventilation, focus, infectious disease, and critical care, toxicology, and nutrition. So, ma'am, I request you to start the topic.
So a very good afternoon to all of you. I hope I'm audible to everyone. So I'll be speaking about vasopressors and inotropes today. It's a very common day-to-day drug which all of us use in the ICU, and every now and then you would be hearing the doctors in the ICU saying, start this vasopressor or start this inotrope. And sometimes it's confusing because some people will be saying it's a start a vasopressor. The other person will be asking you, so what inotropes the patient is in. So are they really the same? Can you tell a vasopressor is same as an inotrope, or both are different drugs? And I hope today's session makes these ideas and concepts clear for you. So the first thing would be, see, always remember our body has, a great this thing when it comes to make sure that, it has to supply blood to all the organs. So the heart pumps the blood, and these are the end organs. I hope you can see it properly. The top one is the brain, the second one is the liver, and the last one is the kidney. So there are a lot of mechanisms happening in the body which make sure that heart will pump blood properly. And all these three organs which I have mentioned and other organs, basically the end organs, they are getting good blood supply and they are perfused well. But for all this action to happen, there are some receptors which are required. Now, there are a number of receptors in the body. Is it possible to cover all of them or learn about all of them? For the present session, no. So I'll be talking to you only about the relevant receptors today. So I hope all of you have a pen and paper with you. The first receptor, which will be very, very important, is somewhere in your blood vessels you are seeing over here. That is basically your alpha-1. Now, why this alpha-1 is important is any drug which acts on it, or will activate the alpha-1 receptor. And when you activate the alpha-1 receptor, it causes vasoconstriction. Constriction meaning you are narrowing the blood vessel, making sure that whatever the blood is there in the vessel, it is getting squeezed and the end organs are going to get it. Now imagine if all your blood vessels, because of alpha-1, are in a constricted state. At some point of time, you are going to get, blood is going to get empty. At that time, your organs will start not getting enough blood. Ischemia may develop. At that time, there is one more smart thing happening over there is the other receptor present over here, which is called your beta-2. Okay. So this beta-2 just acts different to your alpha-1 in the sense that alpha-1 receptor, they will cause vasoconstriction activation. Beta-2 will cause vasodilatation. So that is how the body is managing, making sure your organs are not under-perfused or not getting over-perfused. Just the right amount of blood they are getting. Now, to make sure that this blood supply is entering the blood vessels and going to all your end organs, what needs to pump well? That is your heart. So that is your heart over here. So there's a receptor we need to make sure that the heart pumps well so that your organs are getting good blood supply. And that is your beta-1. So beta-1 receptor makes sure any drug which acts on the beta-1 will make sure that the heart pumps well. There is good contractility, making sure blood is pumped more and more properly out of the heart. So that is both inotropic effect, which is the contractility, and chronotropic effect, which increases the heart rate. Now, for our purpose of this talk, beta-1 and alpha-1 will be more relevant to us because beta-2 is about vasodilatation. When we talk about vasopressors and inotropes, we always prefer having a good blood pressure, a higher blood pressure. So vasodilatation is actually will not be covered in our talk today. Now, the other receptors which you should know is your V1 receptor and V2 receptor, which is where your vasopressin is going to act. So this V1 receptor is again in your blood vessel and V2 is in your kidney. Then you have your dopamine receptors where the drug dopamine is going to act. So important receptors to remember will be alpha 1 in your blood vessel vasoconstriction, beta 2 in your blood vessel. You may also find beta 2 in your bronchial smooth muscle also. That is why when you are giving, nebulizations, there is bronchodilation. Similarly to that, when you are giving vasodilator, it will act on beta 2 and cause vasodilatation. And then you have beta 1 in the heart, which will improve the inotropy and chronotropy, that is the heart rate and contractility. You have V1 and V2 receptors, which will be important, especially when it comes to your vasopressin. And the next thing will be your dopamine. Okay, the dopamine receptors in your cerebral vessels, renal vessels, and your splanchnic or the vessels near your gastrointestinal tract. So as I mentioned, alpha 1, it acts on the vascular. There is compression of the blood vessels, vasoconstriction. You have beta 1 on the heart, which will improve the contraction and the heart rate. Beta 2, which is present again in your vascular smooth muscle, which will cause vasodilatation. The dopamine receptors, which is present in renal, splanchnic, coronary, and cerebral blood vessels, which will finally cause vasodilatation in there. But don't worry, I know you will be thinking dopamine is used to improve blood pressure. Then how is it causing vasodilatation? I'll be explaining that. So summarizing all the receptors we learned over here, we mentioned most of it. Two receptors more are alpha 2, which I haven't told, which is not very relevant over here right now. But beta 3 will be important to you when we are talking about adrenaline. So when I speak about vasopressors, I mean the drug which is going to cause vasoconstriction. It will have more alpha 1 action. It will increase the systemic vascular resistance, or it will increase what you tell the, it will narrow down the blood vessels and increase your blood pressure. When I tell inotropes, then I mean to say this drug is going to have more action on the beta 1 receptor. Understand, beta 2 is not important because it will be a vasodilator. Inotropic action, you need the beta 1 action, beta 1 receptor increase action on the heart. So increase the cardiac contractility. Do we always have pure vasopressors and pure inotropes? We can have, but we also have drugs which can have both the effects. So that's why we need to know which, if you're giving a drug, what do you want the drug to do? Vasopressor effect should be more or an inotrope effect should be more. Now, if you look at all these vasoactive agents, these are also called vasoactive agents, which we spoke right now. Look at this. With the first column, let's go one by one. So you have a drug, you have a vasopressor over here. It is causing vasoconstriction, but you want to know whether the drug has inotropic effect or not. So a vasopressor with an inotropic effect is also called as an inoconstrictor. They are your noradrenaline, your adrenaline, and your dopamine. But what happens if your vasopressor is without any inotropic effect? That means they are pure vasopressors. Their only action is narrow down your blood vessel and increase the blood pressure. No effect on the heart. So there you have phenylephrine. Vasopressin is something we very commonly use. And then you have angiotensin. Now, if you have something, these vasodilators, they know vasoconstriction, there are vasodilators. Apart from vasodilator, they are also having inotropic effects. They are dobutamine, milrinone, and levosimendan. At least dobutamine is what we commonly see, especially in your cardiogenic shock cases. But drugs which are pure vasodilators, but no inotropic effects are nitroglycerin, nitroprusside. So this group of drugs will not be covered in our talk today. We'll be mostly looking at the other three columns over here. When I say vasopressors and inotropes, immediately to your mind, it comes, right? Noradrenaline, adrenaline, dopamine, dobutamine, vasopressin, and some more of the other drugs which I already mentioned. Where are you going to use these drugs actually? In a condition, basically, if I ask you, your answer is going to be shock. So shock always doesn't mean your blood pressure has to be down. Okay, somebody with a blood pressure of 180 or 190, a present blood pressure of 110, 120 can be a shock for the patient. So understand, probably a MAP less than 65 with a drop in your systolic blood pressure more than 30 to 40 at least gives you a brief idea that this patient could be in shock. Associated with that, you may find some rise in lactates, drop in output, other clinical features like altered sensorium. Patient is very irritable and drowsy. And finally, this shock is actually going to, remember those end organs which I mentioned? This shock is going to make sure that these end organs are going to suffer because of insufficient oxygen delivery. And finally, there will be organ damage or death. Now, all the vasopressors, if I summarize with this picture, it is easier to understand when I'm saying that isoprenaline is at the top, the beta action is profound. Okay, so isoprenaline will actually go in your inotrope, so it will be a beta action will be profound, but see no alpha action. But when I go to your adrenaline, noradrenaline, and phenylephrine, they have both alpha and beta. But your phenylephrine, just look at that pure alpha action, hardly any beta action. This is basically to tell you that we have a pure beta, which is isoprenaline. We have a pure alpha, which is phenylephrine. All the drugs in between have both alpha and beta. Now it depends, they may have more of alpha or more of beta. Now, where am I going to use this apart from the shock? Even in your cardiac arrest situations, when you are carrying out your ACLS protocol in the ICU, you are using these vasopressors, especially vasopressor and inotrope, especially adrenaline, and in post-procedure hypotension also. Now, how do they act? Two receptors we, just talked about. So one is your beta agonist receptor. So basically that action is mediated. Just remember this much, that drugs which will act on the beta receptor, the action is mediated through cyclic AMP. This word is just enough because this will be useful for another drug also, which I will be mentioning later. When it comes to alpha agonist, the drugs working on the alpha receptor, it is through this PIP2 or phospholipase C mediated action, causing vasoconstriction. Now, what are the different class of drugs we need to know? We have catecholamines, where we have endogenous ones like dopamine, noradrenaline, adrenaline. Remember, dopamine is the precursor of noradrenaline, adrenaline, meaning from dopamine, your norad and ADR are formed. Synthetic is dobutamine, isoprenaline, and phenylephrine. Other hormones like vasopressin, you have endogenous. Terlipressin is the synthetic one. PDE inhibitor, Milrinone, here that I'll be mentioning later. Calcium sensitizer, levosimendan. So quite a group of drugs which we are using in the ICU. The most common drug in the ICU, all of you know, most of the times your doctors will be telling you, patient is having shock, blood pressures are low, immediately start Norad. But for that, you need to know what does the ampule contain. Now, the ideal dose of noradrenaline is 1 to 15 mics per minute. See, different books, different articles, they can give you a number of doses. So the most commonly followed or the updated one I am using, there might be a slight point here and there difference, but the overall concept is same. Preferably NORAD, it is easier to use, reconstitute as, mics per minute. So 1 to 15 mics per minute, which comes up to 60 to 900 mics per hour. Now, each NORAD ampule has 2 ml. That 2 ml has 2 mg, correct? So that 2 mg is 2000 microgram. Now, you will try to make this NORAD in a 50 ml syringe. We all use normal saline, but if you see those packet leaflets, it will be always mentioned to use 5% dextrose. Although there is nowhere written that, 5% dextrose is definitely better than normal saline, but it is preferred and it's mentioned in most of the packet inserts. Now, this 2000 microgram, you are going to put it in a 50 ml syringe, which makes it 40 microgram per ml. So, that is each ml is going to have 40 microgram. So, if I want to give this, I want to start at 60 mics per hour, I have to give it at 1.5 ml per hour. If I want to give it as 900 mics per hour, I have to give it as 22.5 ml per hour. This is with a single ampule. I'm sure most of you in your ICUs may be using 2 ampules, then you people are using 4 ampules. I have heard people using 8 to 9 ampules also. So if you ask me what is the correct dose or the best dose, this is the ideal dose which has been, advocated or has been told in a lot of books and articles to go about. But is there a fixed higher dose that, this is the maximum? You should not exceed this. No highest dose like that has been defined. And you will also, I am also sure all the participants who are here today, all of you will have a different method of reconstituting NORAD in your ICU, in your institute. Every institution has their protocol. This doses which I'm mentioning over here or the reconstitution is, based on each ampule. But finally, follow what are the protocols in your institution and go according to that. Now, when we talked about those receptors, alpha 1, beta 2, we definitely want to know where is NORAD going to act on. So look at it, beta 1, only 1 plus. That means very minimal effect on the heart. It is not really going to help us with the heart. Look at alpha 1, it is 4 plus. That means very good vasopressor effect. It is going to compress the blood pressure and increase your blood pressure. But beta 2 is minimal. That means very poor vasodilator effect. But don't we want that? Do you really want NORAD to have vasodilatation? No, we want more of alpha 1, maybe a minimal beta 1. So that is what it is doing. That's why a very favored drug across all the ICUs in the world and like everywhere else. Okay. So what is the net effect? Because of your alpha 1, your blood pressure will improve. Your cardiac output is unchanged. Why am I mentioning that? Because you see your beta 1 action is very minimal. That's why not much effect in the cardiac output. Effect on heart rate also will be minimal. Very useful in septic shock. Actually, it's the first line agent in most of the shocks. Septic shock, neurogenic shock, cardiogenic shock. In cases where you don't even know what is the cause of that shock also, it is said that it is safer to start your patient on NORAD. And no defined particular highest dose for refractory shock cases. Based on your institutional protocols, you can go up to the highest dose which has been mentioned there. So in a nutshell, if I tell about NORAD, it is a first line vasopressor in septic shock. In low doses, if required, you don't have a central line, don't worry. You can use it with a peripheral IV line. It is not that harmful. Obviously, higher doses, you need to put a central axis. But if there's no doctor nearby, your patient's blood pressure is going down. If you have started your NORAD in a peripheral line, you don't need to be worried. You have done a good job today. High cardiac output states like sepsis. And what are the problems with NORAD? Cost slightly little expensive more than ADR. It can cause bradycardia. But if you ask me, just now I mentioned that it causes slight increase in heart rate. So why did I mention bradycardia? Have you ever noticed when you have started NORAD, immediately the patient can have bradycardia? Or sometimes, when you're giving BP is low, somebody may in the ICU may tell, just push 1 ml of NORAD or 0.5 ml to improve the BP, and you suddenly see the heart rate dropping down. That is because initially when your BP was low, your heart was working overtime, going on pumping because it needs to meet the demands of the body. Blood pressure is low, so it is pumping over time, making sure all your end organs are getting the blood supply. When you gave NORAD, because of the alpha 1 action, vasoconstriction will happen, blood pressure will suddenly go up. That gives a message to your baroreceptors in the body that blood pressure has gone up. Now we should control the heart. So, the heart, like you rest for some time. So suddenly you notice a bradycardia. But over some period of time, you will notice that again, there will be a minimal increase in heart rate. So this bradycardia will be very transient initially as body's response to the sudden increase in blood pressure when you have started NORAD. It can worsen cardiac output because see, it has more of alpha 1 action and less beta 1. So going on like increasing the alpha 1 action, so much of vasoconstriction, heart also has to pump against a very high pressure. So that can worsen the cardiac output. Visceral ischemia, especially in the IV lines, if you are not careful, there is, extravasation. It can lead to ischemia and gangrene. And sometimes, especially in cardiogenic shock or in cardiac state, because of NORAD's poor beta 1 action, you may need to add an inotrope to improve the cardiac contractility. Next, adrenaline, the most easily available drug, commonly available drug, and sometimes even like for your cardiac arrest situations also you prefer adrenaline. So the dose is going to be 1 to 15 mics per minute. Again, 60 to 900 mics per hour. Every ampule contains 1 ml, which is 1 mg. So that is 1000 microgram. Reconstitute in 50 ml of 5% dextrose or NS. So every ml will finally contain this 1000 by 50 will be 20 mics per ml. So a 60 mics per hour, if you want to start, you start it at 3 ml per hour, or the 900 mics per hour, the highest dose is 45 ml per hour. People use in their ICUs 1 ampule of adrenaline, sometimes even 3 ampules of adrenaline. Again, go by your institution's protocol. When I talk about adrenaline, how is it different from noradrenaline, right? Even though you have adrenaline in both. So remember it the easier way. It is only adrenaline, that was NORAD, this is only ADR. So ADR, you are using it in cardiac arrest situation, you are not using NORAD in cardiac arrest situation. That means there is going to be some action on the heart. So look at that, beta 1 4 plus. So good, like has some inotropic and chronotropic effect on the heart. It also has alpha 1 action. So this drug does a little more what your NORAD couldn't do. That is, improve your blood pressure through alpha 1 action and improve your heart rate and improve the contractility of the heart through beta 1 action. Very minimal beta 2 effect. So what will be the net effect of all this? There will be increase in blood pressure, there will be increase in cardiac output, there will be also increase in heart rate. It is very useful in anaphylactic shock. So it is the only shock, anaphylactic shock, where your vasopressor or inotrope, like whatever you tell your vasopressor inotrope of choice will be adrenaline. Whereas septic shock and like the septic shock, it may not be the first choice because there you use NORAD. In cardiac arrest, you are going to use it. The shock where the drug of choice will, anaphylactic shock will be adrenaline. So again, no defined dose for refractory shock. So in a nutshell, first line especially, see if you have a patient of septic shock. Now that patient develops some sepsis-induced myocardial dysfunction, some cardiac issue. Obviously, when you give NORAD, it is only going to increase your blood pressure. It is not going to help your heart in any way. You need a drug which can do both. So in those cases, you can consider adrenaline. It is cheap, definitely. And then one thing, lactic acidosis. Remember that alpha 3 which I mentioned to you, which is present on adipose tissue. So ADR will act on that, and that is the reason it causes a transient lactic acidosis. Now something which acts on the heart receptors on the heart, that is beta 1. In that way, it will try to make the heart overwork and pump and everything. So it can also increase the myocardial oxygen demand. The drug, which is a very good drug, but probably it has become obsolete. Obsolete, I wouldn't say will be the right word. Probably less used in the ICU because of NORAD taking more and more importance in the ICU, will be dopamine. But our fellow cardiologists are still liking the drug, and they still advocate that for cardiac patients they want to prefer dopamine to increase blood pressure and improve the heart contractility. Now the dopamine dose is 3 to 10 mics per kg per minute. In a 60 kilos person, it will be roughly around 180 to 600 mics per minute. That comes up to 10.8 to 36 mg per hour. Now the thing about dopamine is, below 3 if you use, it has those vasodilatory effect in the renal vessel, cerebral and splanchnic vessel. Remember the DA1 receptor I mentioned. But a dose above 10 mics per kg per minute, it is just going to behave as noradrenaline. So every dopamine ampule is like 5 ml. It contains, so each ml contains 40 mg. So 5 ml contains 200 mg. You will make it a 50 ml solution, and that comes to 4 mg per ml. Looking at the receptor action, dopamine has good action on beta 1 and alpha 1 and minimal action on beta 2 plus. So it is an immediate precursor of norepinephrine and epinephrine, which I already mentioned. The dose-dependent effects are very important to remember in dopamine because less than 5, it is mostly through DA1, DA2 receptor in renal, mesenteric and coronary vessels, and it causes vasodilatation. 5 to 10 will have more of beta 1 effect. So if I tell 5 to less than 5 is vasodilatory, 5 to 10 mics per kg per minute is more of inotropic effect. It will increase the heart rate, increase the contractility. More than 10 mics per kg per minute, it just behaves like NORAD because alpha 1 action will become more than 10. That is why it's very important when you're starting dopamine and dobutamine, you need to know what effect you want of this drug on the patient. And based on that, the dose adjustment has to be done. So dopamine, the only, if you ask me, then why not use dopamine? Because it has good effect on the heart, it has good effect on the blood vessel also. Why do we prefer NORAD? So when that research was done, whether NORAD is better or dopamine is better to start as a vasopressor in the ICU or inotropic effect, both did the same. So it's nothing wrong if you want to start dopamine. But the only issue is when they looked at these cardiac patients, they found that starting dopamine in them they were prone to develop more and more arrhythmias. That is why NORAD was preferred in that case. Otherwise, both are good enough to start. If you don't have immediately NORAD in your ICU, you can still start dopamine, but the dose idea should be very clear. It is an inotrope in lower dose and vasopressor in higher dose. Useful in septic, cardiogenic, and neurogenic shock. Neurogenic shock because they will have mostly bradycardia and hypotension. So dopamine can be used because it has a good beta-1 action also. So in a nutshell, dopamine can be used as a vasopressor. You can give it with a peripheral IV initially if you want. A good drug if you're looking at, something to increase your heart rate. It is a more familiar drug, right? I mean, most of our colleagues have used that. Nowadays, probably you don't see a lot of dopamine in the ICU. Please don't at all, start dopamine thinking at less than 5 mics per kg per minute that it is going to cause vasodilatation in renal blood vessels. So there will be improved blood flow to renal and there will be more renal protection. Still, people are following these concepts in the ICU. Let me tell you, there is no role in renal protection at the low dose, which, I have mentioned. So you can tell anyone clearly that no, low dose dopamine doesn't have any renal protection. It has been proven. The issues with dopamine are it can cause tachycardia because of the heart rate, catecholamine depletion because, it is the main precursor. And same thing, if it extravasates, then you can have visceral ischemia. Now to one of the second stars of the ICU after NORAD. When NORAD BP is not improving with NORAD, your doctor says, start vasopressin, get vasopressin immediately. So it's quite a, star drug in the ICU after NORAD. How is it different? Ideally, we just read about alpha-1, beta-1 and beta-2. Vasopressin doesn't act on these alpha-1 receptors, but still it increases your blood pressure. How does it do it? So it basically acts through two receptors. One is your V1 receptor in your blood vessels and your V2 receptors in kidney. The V1 receptor in the blood vessel, it will stimulate the V1 receptor, cause vasoconstriction and increase blood pressure. The V2 receptor in the kidney will be responsible for accumulation of, water in the body. So through the V1 receptor is how vasopressin exerts its vasopressor effect, that is increasing the blood pressure, but no effect on the heart. Now, if you look at vasopressin, usually the dose is 0.03 to 0.04 units per minute, which is 1.8 to 2.4 units per hour. So look at the vial. It is 1 ml, which has 20 units. You are going to reconstitute vasopressin always in a 20 ml syringe, not in a 50 ml syringe. So 20 units in 20 ml, which is 1 unit per ml. So if you want to give this dose, that is why this dose which you usually see in the ICU, doctors telling you start at 1.8 ml per hour or 2.4, the calculation comes from this. So 1.8 in 1 ml will be 1.8 ml per hour to 2.4 ml per hour. What does vasopressin do? See, no action on the heart. In the vasculature, that is in blood vessels through V1 and in renal through V2. What are the effects? I told you it is going to improve the blood pressure. It is going to reduce cardiac output and pulmonary vascular pressures because the vasopressin, it's such a strong vasoconstrictor that your heart is eventually going to get affected, especially, when it has to pump against such a high, afterload or what you tell the high blood pressure or high vasoconstriction which has been created by vasopressin. It is useful in septic shock. Now, the good thing about vasopressin is even in cases of hypoxia, acidosis, where your alpha-1 receptor also might become less active, even then your vasoconstrictor effect will be retained. That is why vasopressin is considered as the most potent vasoconstrictor. So, in a nutshell, if I talk about vasopressin, it is not a first-line vasopressor. Look at the profound effect it has. Add when especially your NORAD doses are more than 0.3 mics per kg per minute. The doses to be used are 0.03 units per minute to 0.04 units per minute. There is no upward titration of the dose. And consider hydrocortisone, especially if you are going to add vasopressin. So you need to think about adding steroids also. Just a single slide about phenylephrine. I don't use it very commonly in the ICU. People who are working in the anesthesia, like OTs and units, they will be coming across this drug more. The point of putting this slide was I wanted to emphasize on the fact that it is a pure alpha-1 action. See, there is no beta-1, beta-2 action. It's a pure alpha-1 action, 4 plus, right? So, and it has like a shorter duration of action. Mainly, it acts on the blood vessel only, especially in neurogenic shock or hypotension during anesthesia, where you just, want to give a push of a drug to suddenly increase the blood pressure. Phenylephrine is a choice there. Bolus doses of 0.1 to 0.5 mg every 10 minutes. The concerns are again decreased cardiac output because so much potent vasoconstrictor increasing the pressures. Heart will have a bad time, working against it. Very limited data. So on a nutshell, as I mentioned, it's a pure vasopressor. If I ask you, name me a pure vasopressor, you will tell phenylephrine. If I ask you any vasopressor with inotrope, maybe less or, good, you can talk about NORAD, ADR, and dopamine. And short duration, the drug has a very short duration of action. So when we look at vasopressors, MAP goal should be more than 65, but individualize according to your patient. Some patient may require a higher MAP. Norepinephrine or dopamine as the first choice. If there's a confusion, prefer norepinephrine. Epinephrine is cheap, very good, especially if you are thinking of anaphylactic shock or a case of myocardial dysfunction. Phenylephrine or vasopressin should never be used as first line. Add vasopressin only as a second option to noradrenaline. There is no use of renal dose of dopamine. We finished vasopressors. Now, what about the inotropes? That was the second part of the talk. Okay. So, coming to dobutamine, the most commonly available inotrope in our ICU. The dose of dobutamine is 2.5 to 20 mics per kg per minute. That comes up to 150 to 1200 mics per minute, which is around 9 to 72 milligram per hour. So now every dobutamine vial has around 250 mg in this, 5 ml. And that when you reconstitute in a 50 ml, roughly to get this dose, your solution range will be from, infusion range will be from 1.8 ml per hour to 14.4 ml per hour. Look at dobutamine. It has, look at the beta-1, beta-2 action, very strong action. Actually, beta-1 action is more than your beta-2 action. So, as we discussed, beta-1, good heart contractility and increasing the heart rate. Beta-2, slight vasodilation work, but very weak alpha-1. So, not going to really affect your blood pressure much. So, moderate beta-2 and very mild alpha-1 action, which I mentioned. Do not titrate ever dobutamine with your blood pressure because effect on blood pressure is going to be variable. So if you look at the doses, less than 5 mics per kg per minute, predominant beta-2. So it will cause vasodilation. That's why, whenever you're going to start dobutamine, sometimes you may have to start it with NORAD because there can be a fall in blood pressures. When you go to 5 to 15 mics per kg per minute, beta-1 action will start taking over. So increase heart rate and increase contractility. But more than 15, the alpha-1 action may be slightly more. Now, in dobutamine, it's useful in cardiogenic shock. It's a very preferred inotrope because of some good qualities of it. That is, one, it's short half-life. That is, less than 2 minutes. That means the moment if patient is having hypotension, you feel like, no, I cannot continue dobutamine now. You want to stop, but you don't want the drugs effect on those receptors to stay for a long time and the hypotension persisting for a long time. So that ways it is very useful, the moment you stop dobutamine infusion, the effect of dobutamine cause hypotension will stop in some time. It is safer in renal failure. When I'm mentioning about safer in renal failure, there is one more drug which you also must be using in your ICUs, especially in the cardiac part or also especially your, in neurocritical care ICUs also, especially these post-SAH coiling patients sometimes, it's Milrinone. Now, Milrinone also It has beta 1, beta 2 action. Beta 1 action again more compared to beta 2. But the mode of action is slightly different. If you remember, when I talked about alpha and beta receptor, I told beta receptors action is all mediated through cyclic AMP. I asked you to just remember one word, which was cyclic AMP. Normally, once the cyclic AMP is formed, it will go degradation to AMP through phosphodiesterase 3. Now, milrinone is a phosphodiesterase inhibitor. It will try to prevent the action of this enzyme. So, more and more cyclic AMP, more and more improved contractility of the heart and the heart rate. So, loading dose is 50 mics per kg over 10 to 30 minutes. And infusion at a rate of 0.375 to 0.75 mics per kg per minute. The net effect is increased inotropic effect and potent systemic vasodilator. So, milrinone has also a good peripheral and pulmonary vasodilatation. That is why it's very important use in right ventricular failure. The problem with milrinone is you need to adjust doses in renal failure. It can lead to arrhythmias. And the problem which dobutamine doesn't have long half-life. So, even if you stop milrinone, the hypotension due to milrinone can be for a very long time. So if you ask me dobutamine plus milrinone, probably in acute situations, dobutamine can be better where you have septic shock with myocardial dysfunction or cardiogenic shock. Milrinone probably in chronic heart failure cases, especially we have high pulmonary pressures or right ventricular failures. In those cases, you can prefer milrinone. Now, the other drug, probably the last drug we'll be discussing will be isoproterenol or isoprenaline, which you commonly use in the ICU. Remember, like phenylephrine was a pure alpha. This is pure beta. There is no action on alpha. So it has both chronotropic and inotropic. That is, chronotropic is increasing heart rate and inotropic is increasing the contractility of the heart. It is also most commonly you would have used this drug in your ICU for, the patient coming with heart blocks. So bradyarrhythmias. So it will decrease little blood pressure because of beta 2 action. Remember, pure beta action. So beta 1, beta 2, increase heart rate, not much effect on the cardiac output. The dose you start is 1 to 4 micrograms per minute given by IV infusion. So inotropes, the bottom line will be that in patients with myocardial dysfunction, you are going to prefer inotropes. If you have stable blood pressure, you can start dobutamine. If there is right ventricular failure, because milrinone reduces pulmonary artery pressures, it can be preferred. Only problem with milrinone is long half-life and dose adjustment with renal failure. Few lines about methylene blue. It is a drug which has now, recently been coming up because, refractory shocks. You have given all 3 vasopressors. You don't have anything left. What do you do now? So methylene blue, it's a vasopressor sparing agent. It will basically inhibit the nitric oxide synthase and soluble guanylate cyclase and counteract the vasodilatation. So in sepsis, septic shock, there's a lot of vasodilatation. You want something to prevent that. So that is why methylene blue. Bolus 2 mg per kg IV and then continuous infusion of 0.5 mg per kg per hour for 48 hours. When we have talked about all these drugs, what are the complications? So they can cause limb ischemia, stress ulcerations and malabsorption, especially the drugs which are very potent vasoconstrictors. The drugs which, especially like dobutamine and milrinone, can cause a lot of hypotension, tachyarrhythmias. There can be even myocardial dysfunction with Norad and vasopressin. To summarize all these vasopressor and inotropes we have talked about with this slide telling, which action is more. And if you want to know some tips, how do you optimize the vasopressors used in the critical ill patients with hypotension? Individualize your BP goals. Some patient may require a higher map, some patient may require a different map. So find out which patient requires what map. So decide your goal of BP with your doctor. Reassess the clinical status once you start. Don't just start the vasopressor or inotrope and walk away from there. You have to come back and see what are the targets you had set. Are you achieving that or not? Suppose one drug is not working, think about adding a second line agent. Add hydrocortisone, especially somebody who's requiring high dose of vasopressor. Maximal dose of vasopressor, if you ask, it is still not defined. Looking at the different type of shocks, we know septic shock, we know Norad will be the first choice. Second line, you can think of adding vasopressin. Suppose myocardial dysfunction is present, think about adding ADR. Cardiogenic shock, again, noradrenaline if required, dobutamine also for improving the contractility of the heart, or dopamine. Second line can be again adrenaline, dopamine, and some cases milrinone. Anaphylactic shock, it's ADR and ADR. Okay, that we have to remember. Neurogenic shock, drug of choice, again norad. Second line dopamine we can add, because neurogenic shock, most common problem will be the bradycardia, where you will want a drugs with little beta 1 action. Refractory shock, high dose NORAD, high dose ADR and vasopressin, and now methylene blue. You don't know the kind of shock, unknown shock. You really don't know what is going on with the patient. Blood pressure is dropping, start NORAD till your doctor figures out what is the shock. Can you administer these drugs through peripheral venous lines, IV or regular IV lines? It is the concern most of the times. Yes, you can, because first thing is early administration is important. If you don't have central IV access, don't worry, just start. But look for any extravasation injury. In case you have had an extravasation injury also, don't worry, stop the infusion immediately, but don't remove that catheter, because priority is to get a new catheter, new IV cannula, and restart your drug, because your patient's BP is going to fall down. So make sure, stop the infusion, put a new IV cannula, and restart your NORAD or dopamine or whatever infusion you have started. Then from the old IV cannula, try to aspirate the drug and remove the IV cannula. If required, phentolamine can be injected along the edges. And if it's too bad, ischemia is developing, you need to involve your surgical team. So I will end the talk with some important take-home messages. That is, one drug, if you saw, has many receptors, but you need to know the most important ones. It's impossible for us to remember everything. Dose response curve, especially with dobutamine and dopamine, if you don't know what action you want out of the drug, you are not going to give correct doses. So you need to know, you want the inotrope effect or you want the NORAD effect. So dose response curve is very important. There are direct versus reflex actions, like what I talked about NORAD. Immediately when you start, there can be bradycardia, then tachycardia develops. Dobutamine can also have, when you start, can develop tachycardia. So you need to be aware about this. Just because it's septic shock and we were taught today in class to start NORAD doesn't mean you go start NORAD for every patient without giving fluids to the patient. Or a case of hypovolemic shock, in cases of trauma case, you are going to start NORAD but not give blood products to the patient. Volume assessment and resuscitation has to be done depending on the shock and the patient's condition. Addition to that, you are going to give these drugs. Tachyphylaxis, that means at some level, some doses, these drugs might, you can develop tolerance level. So you may need to go on higher doses. You need to be aware about that. No maximum doses noted for most of the agents. Always keep a watch on complications. Keep coming back to the patient and seeing that, is the dose enough? Is it fine? Or do I need to go up or do I need to go down? Is the patient fine? Am I achieving my targets? Thank you. I hope I have made you understand something about vasopressor and inotropes today.
Definitely, ma'am. That was a very elaborative talk, and a lot of you must be wondering that why ma'am is explaining all these receptors. So the basic thing is, if you know the mechanism, you know which receptor is acting, then you know what complications to look for, and you will be able to monitor your patients better. So now we would want to ask few questions, but before that, if you have any doubts, you can either raise your hand on the pop-up. We'll try to answer your doubts, or if you can also text them on the message box. So, any doubts from any of the participants?
You can message even in the chat box if you're feeling shy to ask.
Yeah.
We can go ahead with the questions till they post doubts.
So before we head to the questions, I would like to summarize the. Can anyone tell me the actions of the receptors of vasopressin? Okay, so vasopressin has no action on alpha and beta receptors. However, it acts on V1 and V2 receptors. And for ADR, so it has a predominant alpha 1 and beta 1 action and a weak beta 2 action. And for dobutamine, it has a predominant beta 1 more than beta 2 and a weak alpha 1 action. Just a second. So we would like to ask few questions first. So there's a 48-year-old male. He's a known smoker, no other comorbidities. He has presented with fever, cough with expectorations for 5 days, breathlessness since one day. Came to the ED with a heart rate of
We
140.
can't see your slides actually.
Ma'am,
We can't see your slides.
you can't
That's
see the slides.
Mm.
Okay.
You want to reshare again and put it in
Oh
slide?
yes, ma'am. I'll just reshare this. Was it visible the first time around?
Yes, yes. Now it's visible. You can put it in slideshow.
Is it visible now, ma'am?
Yes, it's visible, but it's not in slideshow. Uh,
Okay.
you can go to the top next to animation. There is a slideshow. So that also.
One second. Can it continue? Is it visible now?
No, it's not actually.
Okay. Is it visible now, ma'am? I think
Yes,
it
yes,
is.
it's visible.
Yeah. So now, what would be the first inotrope or vasopressor of choice? Or what would be the first line of treatment?
Anyone wants to answer based on the case history? So one person has answered as noradrenaline.
Okay. So so IVF can be used initially to improve the hemodynamics, but this may not help in all cases. So yes. So next. So any other options anyone wants to answer apart from noradrenaline? So yes, so this looks like a septic shock. Despite of initial fluid resuscitation, the patient has not responded. So yeah, noradrenaline would probably be the first choice. Now, if there is no doctor available nearby, a patient is having a peripheral IV line. So what would you do?
Any answer? If the patient has a peripheral IV line, what are you going to do? Can you put up in the chat box? The question is actually if you have to start NORAD, but you only have an IV line, peripheral IV line. What are you going to do? Will you start or not?
Uh, I think ma'am has already answered this during her presentation. So yes, of course, when the BP is low, you would rather start NORAD than wait for a central line insertion. So it would be wise to start NORAD in the peripheral line. Of course, inform the doctor and continue further. Okay, we'll move forward to the next question. So this is the case of an old MI with the left ventricular failure with a EF of 30%, presented with pulmonary edema, cold peripheries. He's also hypotensive. So his BP on admission is 70/50. What would be your drug of choice?
The next slide is not shown. The case who spoke just now.
I'm sorry, but I think there's some technical. Ma'am, is it seen now? Because it's saying that it's being shared.
No, here we can only see that peripheral IV line only.
Okay.
Shall I share that
Ma'am,
PPT?
I think there's some. It's getting hung up.
I'll just share the PPT.
I'll stop share my presentations. So someone has answered dopamine, and yes, we can start. That is, I'm assuming for the if NORAD can be given through peripheral line. So I think 4 people have answered that.
So this was the case she was discussing. When you tell, I'll change.
Yes, I think one person. So this is a case of I'll just repeat it again. Case of old MI with left ventricular failure, with a EF of 30%, presented in with pulmonary edema, cold peripheries. He's also hypotensive with a BP of 70/50. So what would be your drug of choice? So anyone else? Someone has said Dobutamine, correct? So anyone else? Any other opinions?
Patient is in hypotension, BP is low. What you are going to start first? You have written Dobutamine, people have answered, but look at the case, look at the blood pressure over there. What will Dobutamine do? It has beta 1 and beta 2 action. Beta 2, it can cause vasodilatation and further drop in blood pressure. So will you really want to start Dobutamine first?
Why adrenaline? Someone has said adrenaline. So as ma'am had explained, the first choice of vasopressor is noradrenaline in this case as well. So once you can start with noradrenaline, and once the BP picks up a little, then you can add a dobutamine for the beta 1 stimulation. Okay, so I think I've answered the next question already.
Yes. So, like after giving the Norad, the blood pressure stabilized. We'll go to the next.
Yes. So this is a 40-year-old male patient with massive trauma, with blood loss, presented to the ICU with a BP of 70/40. So what would be your drug of choice here? So what is the drug of choice?
So somebody has answered Norad.
Noradrenaline, yes. Anything else? Anyone wants to take another attempt? See the case again. What kind of shock is this? Is the so this is a 40-year-old patient with massive trauma. So trauma means there is blood loss. He has already had a lot of blood loss. And the BP is 70/40. So what kind of shock is this? Is this a cardiogenic shock or neurogenic shock, hemorrhagic shock or a septic shock? What shock is this? So hemorrhagic shock, correct. So someone has correctly answered as hemorrhagic shock. So how would you treat this hemorrhagic shock?
So one person has told fluid bolus. Fair enough. You can initially give fluid, but more important than that is
It's a hemorrhagic shock. So what will you give? Okay, you will start fluid. So someone has answered as bolus.
I think that was the fluid bolus he wanted
Bolus,
to write.
yeah.
Blood products, right?
Ah,
What we discussed.
yeah. So just because the topic is vasopressors and inotropes doesn't mean that you will only choose between vasopressors and inotropes. When it's a hemorrhagic shock, you have to give blood. Fluid you can give up till 1 liter of crystalloids, but after that you have to meanwhile arrange the blood.
And a lot of people have answered actually ADR in many things. Remember, the only choice of ADR as first line agent is an anaphylactic shock. Otherwise, rest everything else, Norad is the preferred choice.
Ma'am, also one person is having a doubt that always injection vasopressin 2 ampules. Why 2 ampules have to be used?
We make it usually with 1 ampule. It's not necessary to make it with 2 ampules.
2 ampules, correct.
Depends on your institution if they are following a protocol. We make it with 1 ampule actually. Khushbu has raised hand. Do you want to ask anything? You can put it in the chat box.
Ma'am, I think it's the same person. I think his doubt was regarding the vasopressin, if I'm not wrong. Or if there is a second doubt, you can please again text in the pop-up box. There's one message. So I think this is the answer for the hemorrhagic shock, Trendelenburg position.
Okay. If we don't have any more doubts, Deepa, can we end the session?
Yes, sir. Please, ma'am, conclude the session. Yes, ma'am. Please conclude the session.
Okay. Madhura, you can conclude.
Yeah, ma'am, thank you for this very elaborative talk. I think ma'am has covered everything regarding right from the basics of the vasopressors and from the mechanism of the vasopressors and inotropes, which the receptors they act, and what are the exact doses, how to make the dilution, what will be its side effects, and how to monitor, basically how to monitor the patients, because I think as a nursing staff you are very important when it comes to monitoring all these drugs that are going on. So briefly I would like to request all of you that henceforth you watch out for all the side effects what can occur once you have started someone on vasopressor or an inotrope, and you can help in identifying the type of shock and help in identifying what the more appropriate kind of vasopressor and inotropes as well. And thank you, ma'am, for this very, very educative session over.
Thank you.